Now I would like to invite Dr. Anuradha Chandramohan as our next speaker onto the dais. Dr. Anuradha is an experienced radiologist currently working as the professor and lead of abdominal imaging in CMC Vellore. She is specialized in abdominal and pelvic imaging with particular interest in colorectal cancer. She will be speaking on early colorectal cancer, cross-sectional imaging, challenges and solutions.
Thank you very much. At the outset, I want to sincerely thank Dr. Madhumurli for having me over in this conference. And my topic is going to be on early colorectal cancer and what are the challenges and solutions. So, early colorectal cancer, because we don't have screening in our country, we only see symptomatic patients. An audit of symptomatic patients in a large tertiary care center like a TMH showed that stage 1 and 2 colorectal cancer constituted about 20%. And if we look at the breakdown of where the colon cancers are most common in our country, majority of them, about 75%, are in the rectum and the sigmoid colon. The rest of the colon, the left and the right colon, constitutes only 25%. Keeping this in the background, looking at what is the imaging modality of choice, we would say if it is a colon cancer, the staging investigation would be a CT. And if it is going to be a rectosigmoid, which is the most common in our setting, it should be MRI, would be the modality of choice for T and N staging. If it is an early rectal cancer, I'll come in the next few slides to talk about endorectal ultrasound. And PET-CT is only reserved for assessing recurrence and to exclude metastasis in patients who have pelvic recurrence when pelvic excenteration is being considered, or when the tumor markers are negative and there is a high clinical suspicion, CT is negative and the tumor markers are elevated and we are not able to find the location of recurrence, again PET-CT would be indicated. Otherwise, there is no indication for PET-CT. So with that background, I want to touch upon this topic in these headings. There are challenges pertaining to the choice of imaging modalities, the timing of the study, and challenges in detection and accuracy. Let's look at these one by one. When it comes to colon cancer, detection is highest with CT colonography. But oftentimes in our practice, CT colonography is only done in patients where endoscopy could not be done in a very elderly, frail patient, or when the patient refuses to undergo a colonoscopy, or in a patient with an obstructed cancer and colonoscopy could not be done. So, or a colonoscopy failed patients. Those are the kind of patients we would opt for a CT colonography in our practice. So, this is an example of polypoidal growth detected in an 82-year-old patient who could not undergo a colonoscopy. And so in these set of patients, CT colonography would be the modality of choice. However, in our clinical practice, often it is not suspected. And so we end up doing different CT protocols. It could be CT with contrast, it could be CT enterography, etc. And this is an example of a recent case that we saw in the last week's MDT, where there was a huge polypoidal growth in the left colon, almost measuring 9 centimeters. And we can see that it's a sessile polypoidal growth attached to the posterior wall of the descending colon. And the scope could not be negotiated past this colon, and the biopsy of this was a high-grade dysplasia. So this is the kind of lesions that we see in our practice. And that's one problem. And second thing is CT enterography may be the study that is done in a patient with anemia, and we might incidentally pick up a growth in the colon. And this is an example of a polypoidal pedunculated polyp in the sigmoid colon. So this is easy to diagnose. But the challenges come when we give positive oral contrast, or when there is a PET-CT done as the initial modality to screen for patients with cancer. The FDG in the bowel lumen is going to mask any FDG-avid growths in the colon. So obviously PET-CT might not be the optimal imaging tool. And in resource poor constraints, we still there are areas where barium enema is done, and that could also attribute to challenges in diagnostics. So having said that, let's focus in the next rest of the presentation on rectosigmoid early cancers. And MRI versus endorectal ultrasound is a pointer. Okay, I will show with the, okay, thank you. So MRI versus endorectal ultrasound is indeed $1 million question. So let's dissect this a little further. So in a patient with a T1 or less stage tumor in the colon and in the rectum and the sigmoid colon, what would challenge us is the size, the morphology of the lesion, and the location of the lesion. Shown here is a large polypoidal growth measuring about 4 centimeter, and these are the kind of lesions that we see in our practice. And these large cancers are beyond the depth resolution of endorectal ultrasound. And so you will not know whether the leading margin of the tumor is indeed infiltrating the muscularis and how much of tumor is outside, what is the end stage, and what are the poor prognostic markers. That would be very difficult when we have a very large tumor like this. On the other hand, if it is a very flat lesion and laterally spreading type of early tumor, very flat infiltrating growth can be very challenging to detect using MRI. But high rectal colon, high rectal cancers and rectosigmoid cancers are challenging for both MRI and endorectal ultrasound. This is an example of a very small hyperintense lesion in the right wall of the rectum, and these kind of lesions are very difficult to detect on MRI unless we know endoscopic findings and clinical examination findings. And this lesion was post endoscopic resection, a recurrence at the site of endoscopic resection, and this we reported it as a T3N0 lesion. So a very small rectal growth might be challenging. And this is a recent case that was challenging for us, where on clinical examination, endoscopy, and on MRI, we thought there was a growth in the rectum. And repeated biopsy of this lesion actually was only chronic inflammation, and there was no cancer that could be demonstrated on biopsying this lesion 3 times. So that can be challenging. So all of us have to work together. It was just an area of mucosal ulceration in a patient with prolapse, which was masquerading as a rectal growth to our entire colorectal MDT. So coming to morphology, I already touched upon the fact that the morphology can be challenging for modalities, and what we see in early growths are these kind of subpedunculated polypoidal growths, and at the site of attachment we often see the rectal wall pulled inside. And there could be flat early rectal lesions, like in this example. This is a less than T2 stage rectal cancer involving the left posterior wall of the low rectum, and it's seen here. The submucosa is still intact, and these kind of cancers can be challenging on MRI unless we are trained to look for it. MRI is definitely superior to pick up poor prognostic features like EMVI, tumor deposits, pelvic side wall disease, mesorectal fascia involvement, and skip lesion are another challenge for radiologists, and it's more easier with MRI than ultrasound as a modality, because ultrasound as a modality is more prone for satisfaction of search, and because of that, again, MRI scores over endorectal ultrasound. So when we look at this example, as I scroll, you can see very extensive EMVI along the posterior aspect, and there's a T2 hypointense thickening of the high rectum. And In this very image, we can see another satellite nodule on the surface of the mid-rectum. And as I go down, we can see another area of T2 hypointense thickening with EMVI. And this patient had multiple tumor deposit and multiple tumor deposits. This is an example of skip lesions where multiple focus of the rectum have early T3 stage lesions, but with multiple poor prognostic features like EMVI and tumor deposit. And this is the strength of MRI, and it can pick up all these findings. In this example, I want to demonstrate this T2 hyperintense mucinous tumor, which again has EMVI, which is much far away. These EMVI and tumor deposits are so far away from the primary tumor, which is sitting in the low rectum, anterior wall of the low rectum. And as I scroll up again, you can see these tiny T2 hyperintense nodular deposits on the rectal wall. This is again a skip lesion. Okay. As I scroll up again one more time, you can see another skip lesion. And there are tumor deposits and EMVI much far away from the low rectal cancer, which is almost at the anorectal junction. So with these two examples, I've demonstrated the strength of MRI over endorectal ultrasound. When we look at this table, we can see that the T stage and the N stage accuracy is comparable for both modalities, but endorectal ultrasound is prone for operator dependency higher than the MRI. And the inter-observer agreement again is better for MRI, good to substantial compared to fair to good for endorectal ultrasound. But the advantage is that endorectal ultrasound is real time, and it can be a very good aid for in submucosal dissections and EMR procedures. But it should be supplemented and complemented with MRI in the given milieu that we are in. And so in our country, definitely, I think we see very large sized polyps. And so we should use MRI as a complementary and a supplementary modality in patients with early rectal cancer. So let's move on to timing. Timing is a problem because in our setting, we image concurrently. We do biopsy, endoscopy, and imaging at the same time, and radiologists are not privy to this information, and that is a very big challenge, especially in early rectal cancers. So having a discussion of these cases in the multidisciplinary team is extremely important to arrive at the right T and N stage. And this is very important in early colorectal cancer and in synchronous colon cancers. And what is critical for early rectal cancer more than the advanced is the technique. If the technique is not optimal, then we will not be able to pick up this kind of very subtle T2 stage lesion in a sessile polypoidal growth, which otherwise looks like an early stage. So a standard template with all these findings are incorporated in the reporting of early rectal cancer. Yeah, I'll just take one more minute and I'll finish. So coming back to the slide, we report all these findings in early rectal cancer about morphology, signal intensity, etc. And we touch upon prognostic features and what is very important and what contributes to stage migration in early rectal cancer is the variability in identifying the site of attachment of the rectal polypoidal growth and differences in the understanding of layers of rectal wall and in correctly identifying what is the invading margin of a early rectal cancer. So examples of this is, I'm going to show you a few examples of these. And so this is a sessile polypoidal growth attached to the anterior wall of the rectum, and we can see it enfolding at the point of attachment, and we can see that it's attached to the anterior wall. So reviewing all three planes is very critical in identifying the site of location of the early rectal growth, and that is very demonstrating the intactness of muscularis propria is the key to diagnosing and accurately staging early rectal cancer. And for that, we need to understand the layers of the rectal wall. And the layers of rectal wall are only seen well when the imaging quality is very good. It has to be high resolution T2 weighted MRI, and that sequence alone in the right plane takes 6 minutes on the table, and the money is in T2 high resolution MRI in early rectal cancer. There's no shortcuts to that. And so all the efforts, instead of doing all other sequences, must go into getting that correctly. So this is an example to show you the importance of identifying the site of attachment. The site of attachment of a polypoidal growth is often identified with low focal thickening of the muscularis. So this is a small pedunculated polyp, and that's the head of the polyp. When the head plunges into the anal canal, due to blurring of this image, we might want to call this a T4B stage tumor with infiltration of the puborectalis. But the surgeon will tell us very clearly, no, on clinical examination, puborectalis is absolutely fine. So how does radiologist avoid making that mistake? By understanding what is the invading margin of the polypoidal growth. Invading direction is from the head towards the base. So we know that the growth will first involve the pedicle, and it will go out of the rectal wall at this site, and so T4B is unlikely in this patient. So understanding the point of attachment of the polypoidal growth and the invading margin and the direction of the growth is critical in preventing and overcalling this lesion as T4B. So again, this is helpful when we all work together. This is another example showing you a similar finding where the head of the polyp plunges into the anal canal and protrudes through the anal canal. So what will help radiologists and us as an MDT team is to have common languages, and Haggett's classification of protruding tumor and helps radiologists understand very easily what is the direction of invasion of protruding tumors of the colon and the rectum. And similarly, having a common language like Paris endoscopic classification and understanding it as a radiology community also helps us understand what is the invading margin of ulceroproliferative growths in the rectum. So planes of imaging are very critical. So if we only look at the axial image, we will always overcall this and say this is a T3 tumor. Demonstrating the intactness of muscularis propria in one single plane along the entire base of attachment is what is key to making a diagnosis of early rectal cancer and saying that it is a T1 stage or less. So in this example, the entire thickness of the muscularis is infiltrated, and in addition there is EMVI and tumor deposit, and so we can definitely make a diagnosis of T2N1C in this poorly differentiated rectal cancer. So this is often a doubt among radiologists, and when there is these long linear lines going into the mesorectal fascia, often we tend to overstage it and call it a T3 stage tumor, but that's desmoplastic reaction. And how do we differentiate desmoplastic reaction from tumor? Tumor would have a broad-based tumor signal intensity. They would be short when compared to these long uniform thickness desmoplastic reaction. And so we can easily differentiate these two using this criteria. But should we break our head over it? Really not, because the management of T2 and T3A and B is the same. So we really don't have to worry about differentiating the two and breaking our heads over it. So post-treatment recurrence is reported in a similar fashion. Identifying the invading margin, identifying the polyp attachment again is the key. And this is an example of a subpedunculated polyp that recurred after endoscopic mucosal resection. So how good are we with MRI? Our own audit between 2017 and 19 of about 54 patients showed that the stage migration was very high, and it was about 45%. But the accuracy of MDT staging of the lesion really went up to 89%, which was comparable to the best that was published published on MRI. And so the concordance rates can be very good, provided we understand all the principles that I just highlighted. So I've touched upon the challenges and I've offered few solutions, and thank you very much.
Thank you, madam. That was a very elaborate presentation. And to know the importance of MRI, in fact, MRI and radiologist is the most important person in the management of rectal cancer. And sometimes what radiologist says, even the pathologist cannot confirm, because now the treatment has gone from non-surgical to radiotherapy, and depending upon if the radiologist says there is N1 disease, totally the treatment goes to total neo-adjuvant. So radiologist words have become the most important words in the determining that what treatment a rectal cancer gets. Sir.
I just wanted to ask you about that skipped rectal cancer you mentioned. Just can you elaborate on that? That's one thing we wanted.
Yes. Basically, I think skipped rectal cancers are basically the entire segment of rectum. In that examples that I showed, from the low to the rectosigmoid junction would have multiple focus of cancer, but it is oftentimes on endoscopy you might not pick it up. You might pick it up only in one site. The other side, the mucosa might be completely normal. And so these are the skip lesions that we see in the rectal wall.
The skip lesions.
I'm not sure about the terminology. I've just made up that term called skip lesions. Yeah, I mean, I do not know. I've just called it a skip lesion, but I've known in my discussion with Professor Gina Brown earlier, she often works with pathologists and regarding a concept of tumor budding. And I think what we're seeing on MRI is parallel to the tumor budding that we see. So basically the entire length of the rectum in these kind of poor histological cases might have abnormal tumor cells. So.
Professor Anuradha, I will be very quick. It's a wonderful talk. I wish you had a little more time. I think you have brought in an issue of overstaging with MRI, which I face. And I think when there is a polypoidal lesion or a large lesion in the rectum, when the patient strains, this actually moves in the lumen and even comes out the rectum. And this actually poses a big challenge for us, because the radiologist gives us a T2, T3 staging, and we on biopsy it is a benign lesion. And when we do a staging ESD, we think many times it is not malignant. So this I have seen many times. Thank you so much for doing that.
Yeah.
Thank you, madam. The talk was very much needed for us surgeons.
Anuradha, you just mentioned one of your last slides that you have found in your audit that there's a stage migration. And was the migration to higher stage or a lower stage that you mentioned?
Both ways. It was both, and I've shown you stage-wise migration. For T1 or less, there was 60% stage migration rates. So when we downstaged a higher stage tumor to lower stage, 60% of tumors that we downstaged were indeed correct.
And what was it, the nodal was the staging at the T level only or at the end status also? Was upstaging, downstaging?
Both. Yeah, we often end up downstaging N in our MDTs, and we downstage early rectal cancers significantly in our practice because radiologists often find it safe to slightly overcall. Yeah.